Good morning. I'm Dr. Michael Reardon from the Houston Methodist Hospital. It's my pleasure to talk to you today about the 5 best structural trials of the last year. Always a difficult topic because there's so many great trials. These are my trial disclosures, and I've been involved in a number of the structural trials out there. We're going to start talking about COAPT and MITRA-FR. I know we've talked about these a lot, but I think there's still a lot to learn from these, and they've fundamentally changed the way I look at secondary MR and our treatment of secondary mitral regurgitation. When we look at these two trials, they have a number of similarities, but a number of differences. MITRA-FR recruited 307 patients over a year, COAPT 614 patients for a 2-year endpoint. The EROA that was required in MITRA-FR was 0.2 to 0.4 square centimeters, and COAPT 0.3 to 0.4. MITRA-FR is a little more European, COAPT is a little more US guidelines. They both had to have heart failure treatment, but COAPT had a central review committee, which was very, very stringent. If you looked at the baseline EROA, it's 0.31 in MITRA-FR and 0.41 in COAPT, and the volumes are also larger in MITRA-FR, 552 cc's versus 192 cc's. Residual MR was slightly higher in MITRA-FR, and that led to a hazard ratio that was above 1 in MITRA-FR for the safety and for mortality, and a less than 1 hazard ratio in COAPT. And again, I point out to you the main differences are the larger EOA in COAPT and the smaller ventricles. So when the COAPT data came out, the primary effectiveness endpoint was all hospitalizations for heart failure within 24 months, and it was markedly positive for MitraClip plus guideline-directed medical therapy versus guideline-directed medical therapy alone. Even more amazing are all-cause mortality. It was statistically superior for MitraClip plus guideline-directed medical therapy versus guideline-directed medical therapy alone. Although we've had a number of drug trials for secondary MR and heart failure showing improved survival, this is the first interventional trial of any type, whether it be catheter or surgery, showing an improved survival in the treatment of secondary MR. Now, MITRA-FR actually came out first, and it had a primary composite endpoint of all-cause death or unplanned rehospitalization for heart failure. At the end of 12 months, there was no difference between medical therapy alone or MitraClip plus guideline-directed medical therapy. So why are these two trials so different? This is a paper from Milton Packer and Paul Grayburn. This black line going across the graph is a 50% regurgitant fraction for a patient with a left ventricular ejection fraction of 30% based on the Gorlin formula. And if you go below that line, it's not severe MR. Above that line is severe MR. And this is part of their looking at what they consider proportionate and disproportionate mitral regurgitation. You can see that MITRA-FR falls below the line, COAPT falls above the line. COAPT had more MR, and it was out of proportion for what you would expect from the ventricular dysfunction. One thought about why COAPT may have done better. And this is the same trial looking at it from the Gorlin formula and the severe and disproportionate MR versus the mild to moderate MR, which was proportionate to the amount of heart failure. If you look at the overall trials, they overlapped like this. So there's clearly some overlap of MITRA-FR into severe MR and some COAPT into not so severe MR. So the overarching principles for the management of severe functional mitral regurgitation is that if it's caused by LV dilatation and is proportionate to the LV dilatation, then you target the heart failure and the dilated LV. If it is out of proportion to the LV dilatation, then you can target the valve structures, and that's considered disproportionate MR. Now, the left ventricle and the mitral and aortic valves are interesting. The left ventricle, we thought, was a cone that's been truncated at one end. You can add a membrane across that and punch 2 holes for the aortic and mitral valve, offset them a little bit, and then you add in the valves, and what you see is the blood comes in the mitral, goes out the aortic at a 180-degree angle. This is not a very good engineering setup because the blood has to go in there and turn completely around to leave the aortic valve. What we see is that blood goes into the left ventricle, the anterior leaflet guides this blood in and helps it start into a vortex at the apex to come out of the aortic valve without losing energy. This vortex helps with mitral valve closure, it helps with diastolic filling, it decreases energy loss, and it helps decrease thrombus formation. So it's important when you can to to maintain your anterior leaflet. Now, this is not part of the trial. I'm just going to throw it in because it's very interesting and I've been involved in it. This is the first in man transvenous transseptal neopapillary muscle and coral repair of P2 prolapse. This is replicating what we do as a surgeon and mitral valve repair and what's considered the gold standard of mitral valve repair. The MITRA-clip does replicate the Alfieri stitch. Yes, it works, but it's not considered the gold standard. So this is something that's going to be very exciting to look for in the future. And somewhere in the next couple of years, this is going to be in my 5 best trials, I hope. Now let's move on to the 2 low-risk trials that were presented. There was a partner 3 and the Evolut low-risk trials. Both of these randomized 1-to-1 between the either SAPIEN S3 valve or the core valve Evolut family of valves against surgery. To get in partner 3, you had to have femoral access. You did not for Evolut, although 99% ended up being transfemoral, and Evolut also stratified by the need for revascularization. Both these had leaflet thickening and immobility substudies, and both these trials we followed for 10 years. Now, if you look at the baseline characteristics, they look very similar. The mean age is about 73.5 to 74. There's about 1/3 female, 2/3 male, a little bit different from our high risk and intermediate risk, where it was about 50-50, likely because females are considered a higher risk because they're smaller and get smaller valves for surgery, so their surgical risk is actually higher. And the STS was 1.9 across the board for both trials, amazingly similar. The primary endpoints, however, were different. The partner 3 trial chose the primary endpoint of all-cause mortality, all stroke, and rehospitalization. And this turned out to be markedly positive in favor of TAVR at the 1-year endpoint. The Evolut low-risk trial chose the same endpoint of the 2 intermediate risk trials, which was all-cause mortality or disabling stroke, and using a Bayesian point estimate at 2 years. TAVR was 5.3%, surgery was 6.7%. That gave a posterior probability greater than 0.999, so it was markedly non-inferior to surgery. Now, if we look at the patient flows, there were people dropped out on both sides, surgery a little bit more than what you would see in TAVR, but there was very good follow-up. Now we've moved on to the KM curves. This is the 1-year all-cause mortality for both trials. You notice at 30 days, the TAVR mortality is about 0.4, and the surgical mortality is 1.1 and 1.2. So TAVR is about 1/3 of that of surgery at 30 days. It's a very safe procedure. We go into 1 year, and we see 1% for TAVR and partner 3 and 2.5% for surgery, whereas Evolut's 2.3 and 3.0. This is really just an indication that the partner trial recruited a lower risk group of patients because your 1-year mortality is really reflective of your overall patient risk. Both TAVR and surgery were lower. Both of these were good. The TAVR mortality of 1% partner 3 was astoundingly good. The 2-year data has been presented, and this gap is narrowed and it's closer to surgery. That's not a surprise. 1% is so low, you would expect some regression to the mean. If we look at the Kaplan-Meiers for strokes, they're both very impressive. The 1-year all stroke for partner 3 was 1.2 and 3.1% for TAVR and surgery. Disabling stroke and Evolut was 0.7 and 2.3. You have to remember that embolic protection devices became available halfway through the trial and were not allowed, although there were a very small number used in both trials. If we move on to rehospitalization, rehospitalization was positive for TAVR and partner 3, and it was positive for TAVR statistically and Evolut. The partner used the three-part endpoint of all-cause mortality, stroke, and hospitalization. If we use a similar all-cause mortality, disabling stroke, or heart failure hospitalization in the Evolut trial, based on 1-year Kaplan-Meier numbers, we end up with an absolute difference of 4.5% in favor of TAVR, which makes it statistically positive at the level of 0.002. So here we had 2 trials in low-risk populations, both of which really showed very positive results, which made this such a stunning set of trials, both agreeing. So the conclusion for partner was that based on these findings, TAVR should be the preferred therapy in these low-risk stenosis patients. For the Evolut, ours was that may be the preferred therapy in patients with severe stenosis and low surgical risk. I think what we need to remember is it applies only to the population tested, so you really need to know your trial data. So what is the difference in the trials? There's really only two differences. One is pacemakers. There were more pacemakers in the Evolute trial in the TAVR arm, and it was no different in the PARTNER S3 arm, TAVR versus surgery. The other difference is hemodynamics. In PARTNER 3, surgery actually had superior EOA and mean gradients, whereas in Evolute low risk, TAVR had superior mean gradients and EOAs. And what we notice is safety is the key difference in outcomes in both trials, and most of the benefit from TAVR occurred in the first month. So what is the current status of TAVR after these trials? TAVR is now approved across all risk levels for the two valves tested. This is based on randomized trials. So what will be left for surgeons to do? There'll be plenty left, and we have to remember again that randomized trials apply only to the populations tested. So who is excluded? Bicuspid valve, significant coronary disease, unfavorable anatomy, associated procedures, and anybody appropriate for mechanical valves. In both these trials, you were seen by your local heart team who had to certify that you met the inclusion-exclusion criteria and that your anatomy was appropriate for both TAVR or surgery. One would think that when this was sent up to the Central Screening Committee, all these patients would be accepted. However, in the PARTNER 3 trial, 34% of these that were approved locally were screen failed at the national level, and in Evolute, 14.8% of those that are approved locally were screen failed at the national level. There are a variety of reasons for this, but it's clear that not everybody felt appropriate at a local level by expert heart teams or felt appropriate at a national level, and not everybody's being treated. I think it's also important to look at age. If you look at the PARTNER 3 trial, only 7% of people were less than 65, and Evolute, only 6% were less than 65, and only 1.3% were less than 60. So the 55-year-old, 6-year-old that comes into your office wanting a TAVR, you can clearly do that if you wish, but you have to tell them we really don't have data on people like you. Finally, we've done pretty well in getting the procedure of TAVR down. Now we're looking at how best to care for these people. There's a number of very interesting trials on how to anticoagulate these people, particularly with the issues of valve leaflet thickening and immobility and thrombosis that have been raised recently. The Galileo trial, of course, was stopped early. This is the popular TAVR trial looking for people that need to be on anticoagulation with Coumadin, and this was oral anticoagulation alone versus oral anticoagulation and clopidogrel, and oral anticoagulation alone worked. So this is something very interesting and something I think we'll see a lot of study on in the next couple of years, but it certainly changed the way we approach these patients at this time. I want to thank you for your time and listening to this 5 top trials. Trials get better every year, and I'm certainly looking forward to the 5 top trials of 2020. Thank you very much.